Let me just start by reminding us all of where we are and how we've got here. And I think it's so important to remember in the first instance that at least 12,500 people have died in care homes, or are care home residents who have died attributed to COVID-19 in England and Wales between March the 2nd and May the 9th. And in fact, the latest statistic just announced on Tuesday is that that is now nearly 15,000. So we can imagine that these numbers are going up and up. And it seems to me that the scale is such that it will in the future be regarded as a kind of national shame, I think, if it's not already regarded as a national shame. And in the most recent week, another important statistic is that the number of COVID-19 deaths in care homes was 42%, or 42% of all COVID-19 deaths were recorded in care homes, or compared to 52.8% of the deaths in hospitals. The remainder are deaths in the community. And the mortality, which we've heard a lot about, excess mortality, is up by 50% in England and Wales among care home residents in the first 4 months of this year compared to the first 4 months of last year. Now, we should put numbers on this, because to say excess mortality and all of these words, which are now in the public domain, they don't really have any meaning until we relate them to actual numbers. And that's 20,000 excess deaths just in care homes, or of care home residents, just in the first 4 months of this year. And as we know, our statistics have a very particular way of counting deaths of care home residents, or deaths in care homes. And what's happening is that we're retrospectively upping the numbers all of the time. So it's very likely that that excess mortality rate will become in the future one of the most important measures by which we attribute or ascertain the extent of COVID-19 mortality. I should also say that that care homes must be a place of trauma. With that level of death rate, they must be settings in which people feel real grief and trauma. Let us also remind ourselves, moving on, that care workers too have a higher risk of death from COVID-19 in relation to the general population. They're twice as likely in England and Wales to die from COVID-19 as people in the general population. And they also have a higher death rate, or a mortality risk, than people in the healthcare sector. So that's important to note. There have been over 130 deaths among care workers up to the present time. Now, I'm going to talk this evening. My talk is in two main parts. I have two research questions, as it were. One is what happened, and in terms of what happened, I want to ask what was the policy approach, and also what was the timeline of policy response. And the second, and probably much, much larger question, is why was there this kind of response? And why not a better response, really? And for that, I want to offer a multifaceted explanation that really goes beyond logistics and resources. And there's no doubt that logistics and resources were important, but I want to suggest that the explanation to the situation we find ourselves in regarding care homes is much more complex and much more deep-seated than the question of resources available in the here and now. It's not at all clear how we should assess policy, and my talk is obviously policy focused. We have no manual for how we should deal with COVID-19 in any setting. It poses a completely different, a new scenario to us. And also we're not at the finish line yet, so we have no parameters under which to assess effectiveness or efficiency and so forth. These are the four questions that I want to pose this evening with you in regard to what happened, what policy, what constituted the focus of policy. The first one is, were care homes the target of a specific policy or action plan. So what was the degree of focusing on care homes? Secondly, was monitoring available to care homes, whether we think of monitoring in terms of testing or whether we think of it monitoring of the population, or indeed whether we think of it in terms of mortality rates. Thirdly, staffing, what happened with regard to staffing and workforce support. Fourthly, was additional funding made available, and when? And this brings me to the next point I want to make, is the what is important. But actually, when we're talking about a pandemic, it's actually the when that's really important, because we know that this pandemic circled the globe in what, 1 month, 2 months? So we're down to counting very small amounts of time. And I have on the next slide, which I'll just skip to very quickly, just an outline of the pandemic. I'm aware that there's a lot on the slide. But just if I could say really that March 3rd, and some of this is being revised retrospectively, some of the statistics, the first cases were recorded in January, originally in January 29th. People now think actually it was earlier. The first death, again, provisional figure recorded on March 3rd. We had lockdown on March 23rd. We had policy starting generally from early March. We had the first recorded death of a care home resident or in a care home on March the 20th. And it starts really from then. So we're talking really about 2 months. Just to go back to my previous slide, I just want to offer some clarifications before I proceed. So care home is now a term that's very widely used. I just want to say that I'm using it to refer to care, places that offer care and accommodation. It's the general meaning. Sometimes we call them nursing homes, sometimes we call them residential homes. I have tried where possible to keep the focus on care homes for older people, because that really seems to have been the flashpoint. But I have to say it's very difficult to get information just on care homes for older people. I'm speaking of England mainly. Many people may know that care policy is devolved in the United Kingdom, and as are some of the statistics, some of the funding regimes. So it's safer to talk about England, which in any case accounts for over 85% of the population of the UK. The policy field, for those who are not familiar with the policy, is what we call in this country adult social care. And we call it adult social care to differentiate it primarily from child social care. So adult social care is a very broad field in this country. It's for anyone, care and support for anyone over the age of 18. The older people, people aged 65 and older, are a significant part of it, but it's much broader than that. I'll try to clarify that as I go on, but I just wanted you to be aware of that at the beginning. And we should also say that social care in this country is very different to healthcare. We have healthcare nationalized under the NHS, the National Health Service. We have it available as a right to people, and we have it generally available without charge. Social care is very different. It's under the local authority, so there is huge variation. It is not free of charge. There is no right to it. People have to pass 2 tests to get it. One is a test of ability or disability, that is to show that they actually need it. And the second is a test of means, and that anyone who has assets and resources over £23,000, including the family home, cannot get access to public support if they want to go into a nursing home in this country. So having said the background, let me move on to what the answers to the 4 questions. So the first is, was there an action plan specific for social care, or indeed specific to nursing homes? And the answer is yes, but. So on the March the 3rd, we had a general action plan which prioritized the NHS, and people may remember that that was the plan where that it was in that publication that the kind of 4-phase response of delay, contain, research, and mitigate was first announced. We had to wait for 6 weeks to actually have an action plan that was specific to adult social care. And we had to wait another 4 weeks, a month, for an action plan that was specific to care home support package. So you can see that there was 10 weeks delay, if I could use that word, or there was 10 weeks difference between the first announcement on March 3rd of a plan and the nursing home specific care home support package. And actually, May 15th was only last Friday. I know these days seem to fly by, but it was actually only last Friday. There's just one other thing that I want you to note that's not necessarily on the slide, is the lack of targeting. So the delay is one thing, but there was an absence of targeting on care homes for really 10 weeks, because the April 15th plan was for all social care, all adult social care, which, as I've said, is a very broad field, including, for example, services for homeless people, mental health services, services for domestic violence, among others. So that's the answer to the first question. So what about monitoring? We know that monitoring and testing have become central elements in the fight for against coronavirus. We also know that the policy followed in this country has made testing a very, very scarce resource. So in regard to testing, in late March, and here I have to say, and I think people who know the field will agree with me, that it's quite hard to get the real information, because there seems to be a gap between the announcement of a plan or a policy and the rollout of that policy on the ground. I'm concentrating here mainly on the announcement of the policy. The story of the rollout on the ground, I think, has really still to be told. And actually, indeed, the stories of individual and collective stories, it's very important that we hear them in the future. But in late March, there was an ambitious testing regime announced for NHS staff. If people might remember that the Secretary of State for Health and Social Care, Matt Hancock, made the promise that there would be X number, I think it was 100,000, tests carried out or available daily by the end of April. There's a lot of dispute over whether that was achieved or not. My point really here is that that was primarily reserved for NHS staff. 2 weeks later, it was announced that testing would be offered to everyone needing it in social care settings. And here I underline needing it, because it seemed to be it was only people who had symptoms or who could prove that they needed a test. And we had to wait really for a further 4 weeks until, actually early April or early May, end of April, testing was starting to be rolled out both to symptomatic and asymptomatic people in care homes, among other institutions. By May 11th, there was an announcement of a new digital portal specifically for care home testing. So again, you see the delay here of probably 6 weeks, probably somewhat longer. One other thing that is important in regard to monitoring is the counting of mortality. And on March 5th, as I said, we had the first death recorded. At that stage, it may have been earlier when we look at the statistics. We had the first death recorded on March 5th. And up until April 20th, deaths recorded were deaths through the NHS system, which were deaths in hospital of people who had had a test, a coronavirus test. So it was really only on April 20th or after then that the people who died in care homes from coronavirus were actually included in the statistics. So it's 6 weeks later, and I should remind you, or it's salutary to remember, that by that date in April, the deaths were 600-700 each day in hospitals. So one can imagine if one added the deaths in care homes to that, how high the numbers would be. The staffing and working conditions is a third question, and PPE, that word that has now become commonplace, it stands for personal protective equipment. We also know that that was a very scarce resource in this country. since the onset of the virus. On April the 2nd, there was an announcement that a detailed supply plan for the NHS. Shortly after, it was suggested that there was a supply chain in operation that included care homes. It didn't specifically mention, or it mentioned care homes, but they were put alongside many other providers like GPs, for example, local community facilities. On April 10th, there was a plan to deliver PPE to so-called frontline workers, and the language is changing all the time. And some guidance published. And here you had care homes mentioned again among a very large set of providers. And finally, on May 15th, there was a specific guidance. Again, that's only last Friday. There was a specific guidance to care homes because it was recognized that the channels weren't working through the local resilience forums, through the NHS. At some stage, the army was involved, and that there would be a new route for supplies to care homes, just announced last Friday. Staffing is another important thing. On March 24th, plans to add 35,000 staff to the NHS were announced. 3 weeks later, on the action plan for social care, which was produced on April 15th, it was stated the ambition to attract an additional 20,000 workers to the adult social care sector, which, as I said, is much broader than just care for older people. And that's, I think, a very positive development to note, and I will come back to that at a later stage. The final question for this stage is around funding. And here you can see that there was an additional 3,000, or a promise of an additional 3 billion, 3.2 billion to the local authorities since early March. And on top of that, there was an additional 1.3 billion for enhancing hospital discharge procedures, funding which is likely to go largely to the NHS. The first tranche of funding, of additional funding, which was announced on March 19th, was generic, and it was for care. The kind of heading on it was care for the vulnerable. Again, care for all local authority services. And this was actually true of the second tranche of funding as well, which was announced on April 18th. And there was here little targeting of care for older people, and little specific targeting of care homes. Of course, local authorities have the authority or have the leeway to decide some of the targeting themselves, but I think it's significant that government was not directing them necessarily towards care homes. Finally, on just last week, May 13th, May 15th, there was an announcement of a support package for care homes, specific for care homes, money that we would expect to go directly to care homes. 600 million for an infection control fund and a general support package with a lot of focus on staffing, paying extra staff and so forth, enabling staff so that they don't have to move between institutions, and also providing clinical support in the care homes, indicating, by the way, I think, that there might have been a stopping or shortage of clinical support in care homes in the previous months. So that's that's the answer to the 4 questions. Now, I want in this talk also to raise the question of what we might have expected, what might have been aimed for. And I have 2 slides here that give us somewhat of a critical perspective, or a more critical perspective, on what we got, but also give us a sense of what might have happened had we, or what happened actually in some other countries. And of course, in the second slide, I'm cherry picking a bit, and no country, I think, has had a perfect response. But what might have been aimed for? It might reasonably have been expected that we would have had prevention and we would have had control. But it seems to me that we completely skipped, or almost completely skipped, the prevention side of things. So, for example, we had almost no measures. We had some guidance, but almost no measures to support care homes in preparing and dealing with outbreaks. We had almost no measures to prevent the infection from entering a care home, and it's generally believed there are three routes through which infection enters care homes. The first is from new residents, and here could I just tell you that between March 19th, when there was a new discharge plan announced, for the hospital discharge plan announced for the NHS to free up at least 15,000 beds, and by discharging patients to the community, and the community here would include care homes among other facilities, it was not necessary for the discharged person, even if they had COVID-19, to actually have tested negative for the disease or for the virus before they were discharged to the care home. So that was clearly, I think, and we need again to look at the infection rate retrospectively to know that, but all the suggestions are that that was one route into the care home. The second route is through people visiting, and there was really effectively no lockdown of care homes, and there was a general lockdown, as I said, on the 23rd of March, and previously people, shortly before that, people who were vulnerable had been advised to self-isolate in their homes and so forth, and we were told not to visit our relatives, our mothers, should they be in care homes on Mother's Day on the 22nd of March. But generally, it was before that, it was up to care homes to institute their own lockdown, and that was another way in which the infections into the homes. And the third way was through staffing, with staff coming and going. There was some information about that earlier this week. And we didn't either have measures to monitor potential infections. There was very little testing, as I said. Care homes were asked to just monitor the infections themselves. But up until about early to mid-April, they only had to report if they had more than 2 infected people or people with symptoms among their population. The control, by the time the adult social care action plan was introduced in mid-April, we were in a phase of control. And the government, I think, has done better on this. They have introduced measures to control the infection once it has entered the facilities, but only partly. And as I said, it came relatively late. They've also introduced, but hardly, measures to ensure access to healthcare for residents with COVID-19. It's not clear what happened to clinical facilities in nursing homes over the course of COVID-19, among other locations. There was some measures to manage staff availability and well-being, but they came late. And then there was almost no measure, or very few, to compensate care homes for the impact of physical distancing and other challenges. In the next slide, as I said, so overall, I think it's fair to say the response was inadequate. It was slow. It was generally reactive, if we understand the control phase as being reactive. And it came too late to prevent 15,000 deaths at the latest count. What might there have been? And on this slide, I just want to cherry pick some things that I've taken from international reading on what might have happened. One thing, and this happened in Austria and Israel, we might have had a national task force for the virus in care homes, or a regional task force has happened in Italy, or maybe local task force. At the minimum, we might have expected an earlier subgroup of the SAGE Advisory Committee, and SAGE stands for Scientific Advice Group for Emergencies, and it's that group that has been advising the government. I believe there is a subgroup on COVID-19 in care homes. I don't have any more evidence on what's in the public domain on that, which is very, very limited, but we might have expected that. We might also have expected better measures or measures to enable better collaboration among care homes themselves. China, for example, set up a very, very strong data sharing and integrated IT system among care homes. That's problematic in this country because we have 11,000 care homes and 5,000 providers for care for older people, which I'll talk about later. We might have expected a rapid response team, for example, to support care homes. That is a team that would actually go into care homes once the risk had elevated. That happened in Bavaria, in Germany, and it also happened in Slovenia, I believe. We might have expected increased pay and bonuses for care home workers. There was certainly quite a lot of benefits for NHS staff, for example. Scotland has done this, I must say. They, on the 12th of April, I believe, they announced a 3% pay increase for all workers in the care sector, and they backdated it to April the 1st. I'm not aware of any such measure in England. We might have seen the redeployment of staff from medical to care home settings. So, for example, we've had a lot of talk about the Nightingale hospitals. They're now being disbanded, but there's no talk that the staff those might go into care homes. And that happened in some countries. I believe it happened in Slovenia, I think. And then finally, we might have had measures to reduce care home occupancy when pressure on space, particularly self-isolating, for example, or distancing or so forth. We didn't have any measure on that either. And I have just put at the end of that slide a reference to a site under the auspices of the London School of Economics, which has very good international information on COVID-19, not just in nursing homes, but generally in terms of the policy. Let me move on to the second part of the talk, which is how do we explain what happened and why? So the why question, really. And I'd just like, before I do this, to remind us that it was a pandemic, and while it might have assumed some normalcy, it is not a normal situation. It is an extraordinarily abnormal situation. And we had a lot of the policy had to be made at very short notice, and there wasn't a rule book, as I said. So I just think it's important to remind ourselves in that regard. The explanation, I think, is a complex one or compound one, and certainly there were logistical difficulties caused by, among other things, sectoral complexity. I'll explain that or give you an insight to that at the moment. There was the impact of 10 years of austerity that had predated this and hit this sector and the local authorities particularly hard. And then the third factor that I'd like to talk about briefly is how we as the public think about social care vis-a-vis the health system and the role of the place of social care in hearts and minds. Is there any space left for social care at all in the public imagination and the public heart, really? Now, let me just talk about logistic problems first. And I have two slides on logistic problems. So the first logistic problem is that we're essentially talking about two systems. So it's extreme. I think we could say that a response that was integrated between health and social care would have been the best type of response to coronavirus, not just in care homes, but generally. But we have, as we know, as anybody who studies in this country, we have two systems. And we just don't have two systems. We have two systems that are that separation dates back almost 150 years. They both have origins in the poor law, and local services for poor people. But over time, health became elevated much more as a general, a national entity, as I said, and something that was supported through public taxation. Whereas social care has never become a social right, its funding has never been secure, and it struggled. There have, of course, been many attempts at coordination and integration, some of which are currently ongoing. I counted there, we've had 12 white papers in the last 20 years alone. We've had 12 white papers, green papers, and consultations, and we've had 5 independent reviews. Under current plans, integration is part of the current plan for the NHS. NHS is meant by 2021 to have an integrated care system, and some of these integrated care systems operate in local areas, and we're going to hear, I think, in the questions about one of them. And these require the kind of getting rid of this hard boundary. I think this idea of a hard boundary between health and social care is a powerful way of thinking about it. But progress is slow. There are positive developments, but progress is slow. And I think it is still true to say that when we had the pandemic, it met the NHS and social care as separate funding, resourcing, governance, legislative, staffing, service, and provisioning regime. A second set of logistical problems has to do with the complex structure of adult social care, which is, as I said, governed by over 400 local authorities. There may be more. And it has a very complex funding structure. Some of the funding comes from local taxation, some comes through the NHS, some comes through charges for services, and some comes through a grant from the government. It is very hard for councils to know how much money they will have, because very little of the funding is ring-fenced. Certain proportions of it are. And in the last years, the councils have had up to 10% of their funding, which is ad hoc funding, that they only know really post hoc, once the government has given the grant or they've collected the taxes. But on top of that complex structure of adult social care, we have, when we go to the provision section, the delivery, we have 11,000 different care homes. Just for people aged 65 and over, we have 20,000 care homes in England as a whole. And those care homes are operated by 5,000 different providers. So it's an extraordinarily complex system. More than that, it's outside the public sector by and large. And this is one of the things that's very striking about the United Kingdom, is the lack of the state as a provider of home care or other kinds of care for older people. In this country, the state really, or the public authorities, only provide about 5% overall. The rest is in what we might think of as the private sector, primarily the for-profit sector. So around, I think, 80% is in the for-profit sector, with the remainder in charity and non-profit sector. There's huge variation in scale, but many of the care homes and the providers operate just one care home. So it's extraordinarily difficult. And there's great variation in the needs being met. These homes have to meet very complex needs. There's 40% involved in dementia care. So we have here, the pandemic meets a largely complex, or very complex, largely privatized, marketized by and large, and poorly coordinated sector. The second explanation that I want to talk about is funding austerity. And we've had, as we know, this for almost the last decade, indeed probably the last decade, because austerity set in really after the recession of 2008. And central government to local authorities, central government funding to local authorities has been down by an estimated 50% in real terms up to this year, over the last 10 years. Now, not all of that, in fact, the councils, I think, have done a really good job in protecting adult social care. And so the cuts in real terms are much, much lower. In fact, I think there's a slight growth in real terms of 2% from funding as compared with 10 years ago. But remember that's a positive situation, but the need is actually growing all the time because we have an increasing elderly population. And the way the government protected, or one of the ways in which the government protected the social care budget, was by freezing fees to the providers, that is often the care homes. And this had huge impact. And they did this particularly in the first 5 years of austerity up to 2015. This had a particular impact, really, It affected the operating resources of the homes quite particularly, and it stripped significant quality from the sector, I think. It also set in train other changes that incentivize profit making, upping the scale. So it's much harder for the single operator to work in these circumstances where fees are being frozen. And so you have a change in the sector. You have a greater move towards marketization, a greater kind of upscaling of the businesses and the companies. You also have highly volatile staffing because there was obviously a knock-on in as well in terms of staffing numbers and in terms of wage rates. This is one of the lowest waged sectors really that we have, although the living wage or the minimum wage was rolled out and that helped. But still, it's a very volatile sector with a very high level of vacancies and very high leaving rates. So 3 out of every 10 care workers leave their job every year. And at the same time, because the councils were so stretched for money, they upped the standards to qualify for aid. So you have rising levels of unmet need. Age UK estimates there's 1.5 million people in England with some level of unmet need. And at the same time, you had public dissatisfaction. So pandemic meets a weakened, under-resourced sector on life support. My final explanation, and there are of course others, but I just want in the last few minutes to talk about cultural factors. And I have here on this slide some images which I think will be familiar. And it's quite interesting to look at how the NHS fares in public opinion and how much it has occupied the public imagination. I think it's assumed the status of a national treasure. You may remember in 2018, it had a birthday. It was 70 years old, I think, in 2018. And also it had a birthday present from the then Prime Minister who allocated 20 billion in funding up until 2023. So it has a very clear brand with very strong public support, even though the level of satisfaction with services vary. The level of public support for the NHS was high actually before the pandemic. It's even more high now. It was messaged by the government as being somehow at risk and in need of protection. And you can see there the symbol and the picture of Boris Johnson. Protect the NHS was the main part of the message from really the start of March. And it's still the main message. I mean, it's not any longer because we now have this new slogan. But it's very prominent. And of course, it occupies all the oxygen in that it's really hard to see social care here, even though the rhetoric is of health and social care, actually the meaning is health. And then you have also the NHS has very well organized, I think. It's very strong unions and it's very strong professional associations who have acted, I think, extremely strategically. Now, in comparison, social care doesn't have any brand or logo. I searched for whether I could find a brand or logo, and I couldn't. The public is generally uninformed about it. A survey done by the Local Government Association in 2018 found that nearly 50% of people didn't know what the term social care meant. So it has no public image. And I should say another 50%, or perhaps it was the same 50%, had made no plans for their own care when they get older. But the public's also ambivalent. I mean, most people will say, 80-something plus of people will say they will pay more tax for the NHS. When you ask people, will they pay for their own care or social care in general, they're very ambivalent about that. Whereas in fact, that's what people have to do, because most of the system now in care homes and so forth are people who pay for themselves. There's no authoritative. Another point I just want to make briefly about the social care sector is there's no voice for it. And when you look back over the media, and the media coverage has got stronger and stronger and stronger, it's very hard to find someone who speaks for the care sector as a whole. Care England, which is, people will know perhaps Professor Martin Green, it represents some of the care providers, but only, the care providers are only one voice in this very big sector. We never have any voice for people who use the services or their families, and we have almost no voice of the workers. So there's little organization of the sector as a whole. So here we have my kind of final explanation really, is you have the pandemic meets an undervalued, largely hidden and misunderstood sector. And on the next slide, I've just put it all together. I don't intend to talk about it because I don't have time, but I just want to underline that there is a bigger story here, and that of course now we're into the immediacy of the response and so forth, and it's very important that we attend to the day-to-day, but there is a big reform project that needs to be introduced here. I have two more slides, which I shall work very quickly through, Chair. The first is I wanted to have some, I think there are real positive takeaways from this. I think we have learned, we are doing some things better. We may not be doing enough. We were late in starting, particularly in regard to care homes. So we know from the evidence that there is greater working together at local level. We also know that the organizations are working together better. We know that there are new procedures, like there's better use, for example, of digital procedures. The care homes are now part of the capacity tracker for beds and staffing that was introduced. Generally, I think I started off this by saying that we've had a conversation about care that we haven't had for a long time, if ever. So there's much more visibility for care homes, and I think much more appreciation among the public for those who work in care homes and those who live in them. We have greater recognition for care. I said there wasn't a symbol, but there is one that's, I haven't shown it visually here because I didn't have space, called the Care Badge. It was introduced last year, and the Secretary of State for Health and Social Care has now said that that will be kind of part of official badge branding. We have better data gathering. We have better data gathering on mortality in care homes, for example, but we just generally have better knowledge of the care home sector, which I hope will continue as we go forward. And we have elevated volunteer capacity. People might remember that we had that call for volunteers, and at least 750,000 people responded. Now that was put in the name of the NHS, which was, I think, the kind of overall story here of NHS front and center. But of course, it's volunteer capacity that may, if it lasts, also be available to the care sector. And indeed, some of it is already available to the care sector. My very last slide, Chair, is I thought it would be interesting to just think about some tests. I mean, I should have put that in inverted commas, to see whether a change is whether there is a deep change. And one test I thought would be in the immigration bill that's currently going through Parliament, which, as you know, is introducing a much more stringent immigration regime. And it will be interesting to observe the treatment of care workers in that, because of course there is a threshold, an income threshold set there, or one of the points, one of the focus on which people get points, which has a threshold, I think, of a salary of 25,000 a year or something like that, which is much higher than the average care worker receives. So let's use that test. And a second test, I think we should watch to see, and perhaps also campaign for an inquiry into policy on COVID-19 and care homes. And I think we should also watch and perhaps also campaign for support measures to address the trauma and grief around what happened in care homes. More long-term things we might look for is we need better and more regulated conditions of work in the sector. We need increased generosity of the funding of the sector for the purpose of thinking about it as a long-term care system. We don't tend to use in this country long-term care system, but it's used widely elsewhere. And so I think we have to reduce the reliance on temporary and stopgap funding. We also want a joined-up system of regulation and support of care homes. It's operating in different silos, a more joined-up healthcare system, a national and local government system. And finally, we need as a society to develop how we're going to take care of our older people and how we're going to allow, and whether and to what extent we're going to allow older people to actually live in the community.